Thank you.
Yes, ma'am, we can start.
Yes, welcome everyone for this edition from the Midlife Committee of Oxy. And we have two interesting sessions, one on bone health, another on muscle health. Though both are interrelated and very much dependent on each other, we have brought in specialists to talk about each of them individually, and if there is time, we might have a combined session as well. So to begin the session, we would like to invite Dr. Sambat Kumari, President Oxy, to come and give a formal beginning to this edition.
Thank
I
you,
welcome
Dr.
Dr. Sambat Kumari, ma'am.
Thank you, Dr. Dhanlakshmi and Josephine. See, I welcome you all for this CME on bone and muscle health at midlife and beyond. So this, as she mentioned, we have two speakers, and this is the program which is the brainchild of Dr. Dhanlakshmi. She is the chairperson of our Oxy Midlife Committee. She is spreading the message, bone health, muscle health, and in midlife and beyond throughout Tamil Nadu. Next year, she is the president and she will spread the message from Tamil Nadu to outside state also. All the best, Dhanlakshmi. Now we will, without wasting time, we will go with the scientific. Thank you, Dr. Dana and Dr. Astri and Josephine for this wonderful program. Thank you.
Thank you, Sambat Kumari, for that wishes. And I would now request Dr. Meena to render the Oxy prayer to begin this program.
Good evening. On behalf of Oxy, I would like to read the prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you, Madam.
Thank you for beginning this program with an auspicious note on Oxy prayer. Now, without wasting much time, I would like to introduce Dr. Mohan Kumar. He's not new to Oxy. He had represented Oxy at the last year's Master's Day at Sri Ramchandra Medical College Orthopedician. He's very practical. He's a good friend of mine, and he's actually of orthopedic department at Ramchandra Medical College. And to discuss or have a dialogue with them, I invite Rajshri, our own member Oxy for 25-26, and also the person to talk about this program because she's a lifestyle medicine specialist. So over to both of you to begin the dialogue. How to cope with the muscle health, how to build up bone health during midlife and beyond. Over to Dr. Rajshri and Dr. Mohan Kumar.
Thank you,
Thank you,
ma'am.
madam.
Chitrakala, can I share the screen?
Yes, ma'am.
Good evening, one and all. And today we are going to talk about slideshow. Yeah. So this is going to be a dialogue between sir and me. And first of all, this is about preserving and protecting bone health at midlife and beyond. So why is it important to preserve and protect bone life at midlife and beyond? Bone health is, we know that the life expectancy is increasing and the menopause is happening at an earlier age. Therefore, women in India, postmenopausal women in India, could be living for 3 to 4 decades beyond the menopausal transition. So, and we know that the most serious long-term consequence of menopause is osteoporosis. Approximately 50% of bone loss occurs in the first 5 to 7 years after menopause. And once postmenopausal women have osteoporosis, the lifetime risk of fracture is 40%. So It is very important for us to give them a good quality of life. Therefore, it is very important to know about how to protect and preserve the bone health at midlife and beyond. So how can we prevent osteoporosis and how can we protect the bone life? So if you think of prevention, so the first step would be identification. So first of all, we have to identify the individuals at risk, midlife and beyond. Who are the individuals who are at risk? The second, we'll have to screen them so that we detect osteoporosis early and we'll have to intervene. Timely intervention needs to be done. Sir, to you now, sir, how do we identify the individuals at risk?
Uh, Good evening, madam.
Good
See,
evening, sir.
first, as you told earlier, it is very important to recognize the symptoms early because osteoporosis is one of the silent killers actually. It causes serious disability and even significant mortality to the elderly population, particularly in women, and particularly when they are about the age after the age of menopause. And obviously, the women are more affected than the men. The men gets affected beyond 70 years actually. Some amount of genetic predisposition is also there in this problem, because if your parents are had problems of osteoporosis or osteoporotic fractures, then you are likely to get the osteoporotic problem. And post-menopause, we lose around 2 to 3% of bone loss for every 10 years. And if there is a family history of fragility fracture or personal history of any fragility fractures, definitely the risk is more. But we have two different types of risk factors. One is the modifiable risk factors. Another one is the non-modifiable risk factors. These non-modifiable risk factors are age, sex, and the ethnicity and genetics. These are all the non-modifiable, which you cannot do anything about it. As you grow older, you are likely to develop osteoporosis. In what age you are going to develop is the most important thing, whether you are going to develop at 60, 65 years or 80, 85 years. So you can, by preventing the osteoporosis and its complication, you can lead an active, healthy life between 60 to 80 very easily. And there are some modifiable risk factors like nutrition. If your nutrition is very good, if your BMI is very good, you are unlikely to get osteoporosis. And your calcium and vitamin D intake, if you take properly around 1000 milligrams of calcium, 25 hydroxycholecalciferol, and vitamin D almost 2000 to 2000 units of vitamin D3 every day. If you take it regularly, you are unlikely to get the osteoporosis. If you are not taking properly these two things, they are likely to develop osteoporosis. And some of the drug intakes, for example, if you're taking oral steroids, if you are taking some anti-malignant drugs, those drugs are likely to cause osteoporosis. And some lifestyle factors like smoking, alcohol intake, and those things definitely affect the bone strength. So avoiding smoking, avoiding alcohol intake definitely increases prevents the chance of developing an osteoporosis at an elderly age.
Thank you, sir. Now we will look at how will you, on physical examination, what are the signs? We have taken the history, the family history, present history. Now we'll go to the examination of the patient. Is there any clinical signs or any particular clinical sign that we can identify as the woman walks in?
Yeah, hunchback or a bent spine. This is basically, if the patient walks with this, they already developed osteoporosis. There is no point in talking about prevention. It is only the treatment which is very important. You should try to avoid this osteoporosis by maintaining a good posture and prevention of vertebral fractures. When you're examining, they will have definitely some amount of kyphosis or Dowager's hump in the backbone, or sometimes they might have some history of suggestive of some fracture. Even a trivial fall could have developed a dorsal lumbar fracture, which is the most common site of osteoporotic fractures. And if you examine the thoracic spine, the occiput will not be touching the wall, And in lumbar fracture, it will be very difficult to insinuate 4 fingers between the lower rib cage and the anterior superior spine. So these are all the clinical signs you get, but these are all the signs you get after developing osteoporosis and its complication. It is very difficult to identify which patients are going to develop, but we have definitely well-defined identifiable risk factors criteria are available. But as much as possible, we should try to prevent this Doveger sump or the kyphosis, because these are all usually comes due to complications of osteoporosis. You should try to intervene before this complication comes actually.
So the next step is, as you said, we have to prevent this and we have to intervene before the complications arise. So we look at screening and early detection even before the complication arises. So the screening methods that are available, sir, would you like to go ahead? Or because we are going to go
Of the
into
4 things which is
details.
mentioned in the slide, there are two
Yes,
things
sir.
which are very important. One is FRAX score, which is an online score, and
Yeah.
bone mineral density. We assess it by using a dual X-ray absorptiometry, which is also called as DEXA scan. This
Okay,
osteoporosis
sir.
self-assessment tool, I don't have any much clinical experience on it, and our orthopedic journals and books doesn't recommend that. And the same
Okay.
thing applicable even to calcaneal qualitative ultrasound. It is even though it is a very simple machine which can be used in your clinic, but it doesn't tells the exact
Yes, sir.
assessment of the bone mineral strength, because calcaneal bone, usually very rarely we get osteoporosis in the calcaneal bone, because it is one of the weight bearing bone basically. So
Yes.
usually it is the last one to go for osteoporosis unless they are bedridden or
Okay.
something. So we are
Yes, sir.
supposed to detect it before the
Early.
calcaneum becomes osteoporotic. So this OSTA and the calcaneal qualitative ultrasound is not clinically followed in my experience, whereas the SFRAC score, which basically assesses different line of
So we
questionnaires.
will go into the details
Yes,
later, sir,
yes, yes,
with the
yes.
case. Thank you so much, sir. Thank you, sir, for highlighting that. Yes, the calcaneum is the last bone to get affected, and so it will not be a pre-screening. It will get affected last, and that's very a point that you have highlighted, sir. Then the final step, as we have said, is the timely intervention. So we have finished the risk assessment, we have done the screening, and then we have to intervene, which could either be a lifestyle modification or appropriate medical management. Now we will go into a case scenario. Here is a 52-year-old lady. She underwent hysterectomy at the age of 47 years for fibroid uterus, along with removal of ovaries. Her mother had hip fracture at 75 years, and she passed away due to fracture-related complications. She has low backache for the past 6 months, which is aggravated in the past 1 week. She has type 2 diabetes mellitus for 2 years, and she's on oral hypoglycemic agents. No other medical problems. She's an occasional smoker and social drinker. Her BMI is 21.4. So here we are getting all the risk factors about the BMI, the smoking, the alcohol, the risk fracture, hip fracture, a mother's hip fracture, all these histories there. And beyond that, she has underwent a hysterectomy with removal of the ovaries also for fibroid uterus. So what would you, when she comes to you, what would be how would you like to screen her, sir?
See, she is definitely a very high risk for osteoporosis, because she already had ovaries are removed and she's crossed that 5 years post ovary removal, and there is a genetic predisposition is there, and she's also a smoker and alcohol, even though it is occasional, and she complains of some pain in the back and the dorsal spine, which is an indicative of a fragility fracture, most probably in the vertebral body. Unless you intervene, unless you take X-ray or MRI, you will not be able to pick up the small crack fractures. Very often, patients with presents with only a diffuse pain in the back or the hip region, they won't give any history suggestive of any fall or anything. So this patient definitely needs to be investigated, and we must do a DEXA scan to assess the risk factor which is involved in this.
So a DEXA scan need to be done. These are the, so would you like to tell us, sir, when a DEXA scan needs to be done routinely, not for this women?
See, DEXA scan, yeah, as you mentioned in the slide, It covers all the points actually. In all women post menopause after 5 years. Usually, first 5 years they don't develop any symptoms. After 5 years only they develop the symptoms and early signs of osteoporosis. And patients with less than 5 years who has a particular risk factors, for example, if they are taking oral corticosteroids for some other medical problem, and patients who present with fragility fractures. If the patient presents with the fragility fracture following a very trivial trauma, if they develop a fracture neck of femur, trochanteric fracture, or a Colles fracture, or a wrist fracture, or some vertebral body compression fracture, then these are all the patients who are likely to must go for a DEXA scan to assess the exact BMD strength. And patients who had a transition with the secondary causes, and if there is a radiological evidence of osteopenia and vertebral compression fracture is there, and DEXA scan is a must before starting the patient on any pharmacotherapy. Any drugs other than calcium and vitamin D supplements, if you are going to start on any specific drugs, then you must do a DEXA scan because it is very important prerequisite.
Thank you, sir. So how will you interpret a report?
So
DEXA.
this slide tells very clearly about between the normal BMD and the severe osteoporosis. This basically the DEXA scan gives two scores actually. One is the T score, another one is the Z score, which is usually the T score is the one which is mostly used. T score is basically of an individual whose mean BMD is of less than 22 BMD of less than 2.5%. To the patients who are at the same age group of the Caucasian females. It is not assessing the Asian females. It is till now it is assessing only the Caucasian young females, their age. That is about the T value. Whereas the Z value is basically assessed the depending upon same BMD assessed standard deviation from the age, gender, and the ethnic group of the reference population. But even though it gives two values, the T value is the most important thing, which tells in the normal BMD, it is basically anywhere between -1 and +1 standard deviation. And in low BMD or osteopenia, where the T score is between -1 and 2.5. And in osteoporosis, if the T score is less than 2.5 or lower, and severe osteoporosis, patients who present with the fracture with the BMD score of less than 2.5. So this T score definitely gives us an idea about the extent of osteoporosis in a patient, and we can do this DEXA scan for the hip region and the vertebral body region. These two regions are usually done. Sometimes we do it for the wrist also if necessary, but usually vertebra and the spine hip region is more than enough to get a reasonably good T score.
Thank you, sir. So you've already said about calcaneal quantitative ultrasound. It had a high specificity. I mean, but the sensitivity was low, as you said. The sensitivity is only 53%. Specificity for predicting bone mineral density.
Yes.
Yes. Then next about what is fracture risk assessment tool or FRAX tool?
See, this FRAX score is basically a computer-based algorithm. It basically gives us an idea about 10-year probability of hip fracture and major osteoporotic fracture according to the individual's risk factors which are involved. And it depends upon the country, bone mineral density, age, gender. So these are all the points which are given. You mark the age, sex, weight, height, history of previous fracture, any parent with a fractured hip, current smoking, intake of glucocorticoids, patients with rheumatoid arthritis, patients who have secondary osteoporosis, any alcohol intake, and femoral neck BMD. So BMD is very important, which tells us about the what is the score. So based on this, we can calculate how much is the chance of a 10-year possibility of a osteoporotic fractures. It is available online, and it basically gives you three important things. One is the low risk individuals, high risk individuals, and very high risk individuals. In low risk individuals, you can optimize by giving calcium and vitamin D supplements, and you can give some exercises and reassurance and lifestyle advice. And even though it mentions about the hormonal replacement therapy, which is we don't practice in orthopedics. In orthopedics, we don't practice hormonal replacement therapy unless it is indicated for some other gynecological reason. If it is indicated for some gynecology reason, then definitely you can give estrogen supplement. In high risk individuals, you have to take good calcium and vitamin D supplements and appropriate exercise and fall prevention. And usually we start the patient on oral bisphosphonates or other inhibitors of bone resorption. In very high risk cases, you have to give vitamin D supplements and calcium and appropriate exercises, and start giving them anabolic agent followed by inhibitor of bone resorption. In this inhibitors of bone resorption is we have teriparatide, we have denosumab, we have alendronic sodium injections, and oral bisphosphonate. These are all the drugs which are available for once the osteoporosis is identified.
Yeah, we also have to tell her about the chances of prevention of falls in the house. What are the changes at home she should make, and she should be careful. If need be, we'll have to even give her certain equipments or apparatus if she requires for prevention of fall. That is also one thing which we have to take care of to prevent complications. I mean, a word about osteoporosis self-assessment tool. It protects solely on current weight and age. It predicts the risk of osteoporosis because this is studied in Asian women and had a 91% sensitivity and 45% specificity. So what is the osteoporosis score is weight, present weight in kgs minus age in years divided by 5. If it was between minus 20 and minus 4, the risk is very high, 61%. Between minus 4 and minus 1, it's moderate risk, which is 15%. And minus 1 to 20 is low risk, 3%. Because it has been studied and the sensitivity is high, the women can do it herself to find out the risk of osteoporosis. So this is the self-assessment too. So now we are continuing with the case, and as you said, DEXA scan was done, and this is the report, sir. How will you interpret this report?
Yeah, which is definitely both in the lumbar spine and in the hip region, the T-score is minus 2.8. So definitely there is evidence of osteoporosis is there.
Yeah. Okay, so there is a definite risk of osteoporosis. So before we proceed into management, how could we have prevented or could we avoid, would it have been possible for us to avoid osteoporosis in the lady? She's come at say 47 for a hysterectomy. At that point of time, what are the things that we would have considered and we would have done, knowing that the osteoporosis is definitely a complication of menopause. So there are three things that we have to consider here. One is the lifestyle modification that we have to stress on. It is very important to tell all our patients who come to us about the lifestyle modification. We'll consider about the role of menopausal hormone therapy, and the ovarian preservation conservation is a very important point when she undergoes a hysterectomy for a benign condition like fibroids, if it is myoma, if it is possible here. See, even if it is got to conserve at least till the natural age of menopause, we must think of considering the conserving the ovaries, because we know how important it is, ovarian preservation and conservation. So next, coming to the lifestyle modification, we will start with the nutrition. We know we have already said the importance of calcium and vitamin D. So dairy products, leafy green vegetables, vitamin D, fatty fish and fortified food. But then we all know the main source is sunlight. So exposure to sunlight, 15 to 30% of the body surface. So the upper arm, neck and face, about 15 to 30 minutes between 10 a.m. and 3 p.m. is very important for the vitamin D, because we only from fortified foods we can get. So we all of us need to have the sunlight exposure, and maybe we'll have to check the vitamin D. If needed, we need to take the supplements. Fruits and vegetables, 5 servings of fruits and vegetables are very important every day. They have antioxidant properties, anti-inflammatory properties, and they are alkaline precursors, and they promote bone formation. So phytoestrogens, we know, they are estrogens from plant varieties. So lentils, kidney beans, Bengal gram, and soybeans could be included in the diet because they will provide some phytoestrogens. And a balanced diet with at least 0.8 to 1 gram per kg of protein per day. So when there is a stress like menopausal period, we can even go up to 1.2 gram per kg of protein per day, though the normal is 0.8 to 1 gram per kg per day. And the polyunsaturated fatty acids, the PUFA and the nuts and seeds will also help in calcium absorption. Make sure that you take at least a minimum of 8 glasses of water per day. Avoid processed food and sugary beverages. All these will prevent absorption of calcium. Restrict salt to 5 gram per day. Limit caffeine intake to less than 200 milligram per day, and also avoid excessive consumption of alcohol. In the women health study, 1.2 grams per kg protein, there was a 32% lower risk of frailty and improved physical function in women. And getting 3% more of total calories in the form of plant proteins like beans, nuts, and whole grains. Like I said, the grains should be whole grains that we have, lowered people's risk of premature death by 5%. So make sure that you take calcium at least 1200 milligram per day, 600 international units of vitamin per day, vitamin D per day until the age of 70. Then it should be increased to 800 international units. So next, coming to exercise, it is very, very, very important that as we have to stress it. You can see the Will's law that use it so you don't lose it. So if you do not have to lose it, you definitely have to exercise 150 to 300 minutes of moderate intensity aerobic activity each day. By moderate intensity, we mean that you should be able to converse while you are talking. So you should not be able to sing. It should not be that slow, but you should be able to converse. You should not become breathless. And it will be like jogging, running, brisk walking. And that is the moderate intensity, 150 to 300 minutes. So we could go more towards 300 minutes. And 30 minutes of muscle strengthening exercises. Muscle strengthening is very, very important. And the next topic is going to be on sarcopenia and the exercises. So I am not going into detail about the exercises. At least 2 days each week, depending on the time you spend. If you're spending lesser time, then you can do 4 to 5 days also. Flexibility and stretching are very, very important to prevent falls, to improve posture, and for the activities of daily living. You have to be independent. Your quality of life has to be good. So the flexibility and stretching like yoga, pilates, tai chi are very, very important. And also exercises to improve posture and balance and prevent falls. Because in this lady, we also have to tell her about, she may go in for osteoporosis and prevention of falls, fragility fracture. When she is got osteoporosis, we have to explain about fragility factor and prevention of falls and what are the things that she has to undertake to prevent falls both at home. So this reduces the risk of osteoporosis, heart disease, dementia, and cancer. This is the guidelines that is being provided. So when we talk about lifestyle modification, we just don't talk about one. So it rests on all the 6 pillars of nutrition, exercise, good sleep, that is restorative sleep, stress management, social support, and avoidance of risky behavior. So even if one pillar is at fault, it will affect all the other 5 pillars. So it's very important that sleep of 7 hours or more per night on a regular basis to promote optimal health. That is by the American Academy of Sleep Medicine. We know that when the quality of sleep is disturbed, there is going to be stress. Again, there is going to be difficulty in weight management. She will not be altered mood will be there. She will not be able to do her exercises. So it's going to affect the other pillar also. Again, stress causes weight gain and mood changes. The cortisol and adrenaline will have its effect on the bone also. And being social, having a social support and being socially connected is very important, because there are fewer menopausal symptoms with greater family support, and the resilience and the longevity increases. So changes of perimenopause and menopause are easier to negotiate when they interact with women of the similar stage in life or the same age and situation. So considering the role of menopausal hormonal therapy, as Sir has already said, though it improves bone health by preventing bone loss and reducing risk for osteoporosis, it should not be used only to prevent osteoporosis. He said that it is not given in the low risk. Yes, it should not be used only to prevent osteoporosis. But when we start, like in this lady, I call it's a surgical menopause. So we can start her and continue up to natural age of menopause. We can give it in primary ovarian insufficiency, premature menopause, surgical menopause before 50, and iatrogenic menopause before 50. So now coming to what are her treatment options, sir?
So this slide mentions about the four drugs other than calcium and vitamin D supplements. These
Yes, sir.
four drugs are very commonly used: bisphosphonates, denosumab, teriparatide, and zoledronic acid. But the last one, this calcitonin, we very rarely use it for osteoporosis, even though it inhibits calcium resorption. It is usually given for when somebody presents with osteoporosis with the bone pain. It is supposed to be very good for bone pain. So it is not a very commonly used drug. Whereas this bisphosphonates, denosumab, and teriparatide is very commonly used. And specifically for vertebral fracture, teriparatide is supposed to be very effective. And bisphosphonates are supposed to be very effective for hip fractures. And denosumab is basically immunomodulator, which is a very good drug because it is a very low dosage and it should be given once in 6 months actually. That is a very easy thing about this. Whereas the teriparatide is a only problem is it has to be taken like insulin. You have to take it almost every day. And bisphosphonates, there are oral bisphosphonates available which you can take it daily, or you can take it weekly, or you can take it once a month. And there are IV injections available once a year also is available. But only thing about bisphosphonates is some people doesn't tolerate this bisphosphonates. It can cause gastric irritation and can cause gastric motility problems. So they may not respond well to bisphosphonates. So in those patients, we consider denosumab and teriparatide. Teriparatide only problem is, as I told, it is to be given injection every day. And denosumab is the best advantage is it's a monoclonal antibody. It is given for once in 6 months. A little expensive, but if you consider the treatment like teriparatide everyday injection, it is almost equivalent to it. And all the three drugs has to be given for at least minimum 5 years, and they should be followed up with once in alternate years. You should check the DEXA scan.
Okay. So yeah, that's what. How will you follow up this patient is your next question that I. Yes, sir.
So that's what this basically tells about if there is a osteopenia, then if there is a T score is less higher than 1.5, then you repeat DEXA scan only if the risk factors are increases. If the T score is minus 1.5 to minus 1.9, then you repeat DEXA scan once in 5 years. Whereas if the T score is 2 to 2.4, which indicates of osteoporosis, we repeat the DEXA scan every 2 years. If it is less than that, 2.5 with associated fractures, then you might consider even less than even less than 2 years also. But all these drugs, these bisphosphonates, alendronic sodium, and teriparatide, denosumab, all these things acts very slowly. It takes really long time for it to come, and you have to give it for at least for a period of 8 to 10 years to have a very good effect on that actually.
Okay, sir. Thank you, sir. So I think we have done with this case. The take-home messages will be attain a good peak bone mass. This is very important because once you attain a peak mass, that's around 25, 30, you're there, then you start losing. As we have explained, to prevent, identify the risk factors, screen for osteoporosis, osteopenia, bone-friendly lifestyle modifications, and suitable prophylactic and therapeutic management. Strategies to prevent fall also have to be included along with this. Sir, anything that you would like to add now, sir?
Yeah, it's good. I think we almost covered everything. One more thing is you have to increase the exercise. This thing, which you already have a next talk, which is about sarcopenia, because sarcopenia is one of the things which goes along with osteoporosis. So
Yeah,
as
that's why I didn't elaborate on the exercise. That's what I said. They are going to do it in the next talk. That's why I didn't elaborate on the exercises, sir.
Along
It
with
improves
the
bone mineral
management of
density for sure. Yes,
yes,
sir.
along with management of osteoporosis, improving the muscle mass is also very important. Because when in our practice, what we see is most of the time people who are beyond 50, 55 years, they have a very poor muscle mass actually. And because of that, they lose balance and they have a fall and comes to us with a fracture. So it is important to stress about the sarcopenia also in these patients.
Okay, sir. Thank you so much, sir.
Thank you. Thank you, madam.
Thank you, Dr. Mohan and Dr. Rajshri. There's a question in the chat box. What are the toxic drugs, bone toxic drugs that are to be avoided?
Bone toxic drugs, basically steroids, basically. Oral corticosteroid given for other problems. is definitely likely to definitely likely to affect the calcium and vitamin D intake. They are and long-term usage of this can lead to even systemic osteoporosis. So you have to be very cautious about when they are taking corticosteroids. And of course, some of the anti-conversion drugs like phenytoin sodium and some drugs like proton pump inhibitors, which commonly we use pantoprazole, rabiprazole, in long term, they also supposed to cause osteoporosis. So we have to keep a check on them whether they are taking those drugs also.
And somebody has written about avascular necrosis of the femoral head.
Avascular femoral lead usually is not due to osteoporosis. It is basically mechanically the blood circulation to the femoral vessel is affected to the femoral lead, which can lead to osteoarthritis of the hip. It is not. It doesn't. It is not cause for osteoporosis.
So what about inhaled steroids for asthmatics? Will it cause osteoporosis?
It is very rare. There are a lot of studies have come because it is extensively used in particularly in bronchial asthma patients. It is very rare because the dosage is very small and it gets absorbed only locally. It doesn't have much of systemic spread actually.
Thank you. It was a very lively dialogue. I would say very
Thank you, sir.
practical, and I really enjoyed getting the essence of maintaining bone health at midlife. And I think it should start much earlier when you want to have a good bone health at midlife. The practice should start much earlier, and that point was driven very well to the audience here. And I am very happy to introduce another interesting personality here to discuss. It's a kind of question answer session which I'm going to have with Dr. Chrysolite Mohanan. She's from Ramchandra Medical College. She has done a master's and bachelor's both from Ramchandra, and she has a certificate course from Michigan 2010, and she is also has a fellowship related to physiotherapy, osteopathy, and manipulative therapy from Australia in February 2024. And she's currently pursuing a PhD on efficacy of structured exercise care on the quality of life among individuals undergoing hip arthroplasty for femoral fracture since August 2021. And all the best to you for your PhD program, Chrysolite. And I welcome you to this program. And I am very happy to introduce to this audience who are very keen to know about what should be done to improve a muscle strength or keep the muscle at good health around midlife and beyond. When should we start actually?
My screen is visible.
Yeah, thank you. Yeah, screen is very much visible. You can go to the next slide. So, as we are talking about muscle health, are there any simple screening tools in the clinic which we can set up in our own clinic, in a gynec clinic, which can tell about muscle health? Suppose a patient comes at 45, 50 and for some other gynec issues. We also want to address this muscle health at that time, whether they are having complaints or not, whether we want to give a piece of social message to them. How do you go about it?
Yes. When a patient walks into the clinic, usually just by observing the patient, the way the patient walks in, the speed at which the patient walks in, the handshake, the strength of their handshake, all this will actually give us a clue whether this patient is really sarcopenic or having some muscle weakness. So the weakness, the visual identification of low muscle mass, their speed, as I told, weight loss, if at all we see muscle weakness, fatigue, they come to us and tell frequently they become tired, any history of fall, loss of energy, all this will give us a clue about the sarcopenic status. And there's one questionnaire called SARCF question. It's just 5 questions which we can ask. And like the first question is about strength. How much difficulty will you have to carry 10 pounds of weight across a room? If they say I can walk without any difficulty, we mark it as 0. Some difficulty, we give 1. And if they say I'm not able to, then we give a score of 2. Similarly, the next point, assistance in walking. So we ask them how much difficulty do you have walking across a room without any weight? Even that, if they say I have little problem in walking, I need walking aids to walk, all this will give us a score of, out of 2, we'll score them at 0, 1 or 2. So totally out of all these 5 points, rising from a chair, climbing stairs, and any history of fall. So if we ask them these questions, we'll get a score out of 10. If the score is out about 4, it tells us probably the patient has sarcopenia and they need to undergo some assessments. That will be the next score. So this is all now. The SARCF questionnaire along with the clinical presentation with which the patient walks and comes inside the clinic, we get a clue about their muscle strength.
So what are the methods of evaluating this muscle health? How do you evaluate them?
All right. Once we feel like this patient may be sarcopenic or probably sarcopenic, we need to evaluate the patient in 3 aspects. We need to assess the muscle mass, the muscle strength, and the performance of the patient. The first one is calf girth test. Is a very simple test which we can do it in the clinic using just an inch tape. Next is the hand grip strength. According to the sarcopenia studies, hand grip strength, just gripping the hand fingers around a dynamometer tells us it's a proxy of the overall body strength. And we have simple tests which we can do it in our clinic, like 5 times chair stand test, timed up and go test, 6-meter gait speed test. I'll show you the testing now. So this is calf girth test. We just measure the patient's calf around the maximum area of calf. So when we measure, we compare it with the other side. After doing the measurement, we need to compare it with the normal cutoff values. So according to sarcopenic studies, females with less than 33 centimeter of calf girth, they are probably sarcopenic. Next is the hand grip strength. We have a dynamometer, which the patient has to grip and just press, just for 3 seconds. So the reading there can tell us whether they are sarcopenic or not. In males, if they are not able to press more than 28 kgs, if it is poorer than that, they are sarcopenic. We need to evaluate them further. For example, for females, if the hand grip strength is only 18 kgs or less than that, they are probably sarcopenic.
That video was not running, Chrysolite.
Yes, ma'am. I'll check again, ma'am.
Yeah.
Ma'am, now?
Okay.
It's just pressing the hand held dynamometer.
Okay.
Nothing much, ma'am. Next one is 5 times chair stand test. It's just asking the patient to rise from chair 5 times, and we note the time they take for 5 chair raises. Even for this, age appropriate as well as country specific cutoff values are there. So in India, if they take more than 6.48 seconds to sit and get up 5 times in this age group, for example, 40 to 44, we can say they are sarcopenic. And this is another simple test. The patient has to get up from chair, walk 3 meters, go back and sit. The time taken for this is noted as the timed up and go test, and this time is also compared against normal age appropriate cutoff values. So if the patient walks very slowly, if they're not able to walk within, for example, if the age group is only 31 to 40, they should finish the test within 7 seconds. If they take much longer, they are considered to be sarcopenic. And this one important test for physical performance. The patient has to get up, walk for 6 meters. So the speed at which they walk can be calculated. So how long they take to walk that. So in seconds we calculate, divided by 6 meters will give you the speed. So distance by time is speed. So 0.8 meters per second. If at all the score is less than that, it indicates the risk of poorer outcomes in these group of people.
So what are the, suppose you identified women with sarcopenia, if they had come to you, you had identified them with their clinical presentation, how they walked into your clinic, and then you also did all this test, and then you identified certain group of women who have sarcopenia, and how do you go about recommending basic tests for them to improve the muscle strength?
The exercise recommendation.
Yeah.
Okay. For sarcopenia, the established exercises would be resistance exercise, aerobic exercise, balance exercise, because once their muscle strength is poor, when they are weak, they tend to fall. So we need to concentrate on their balance aspects also. So we give balance exercises because it's muscle. We need to stretch and keep your muscles flexible. So we go with flexibility training, and multimodal exercises is a combination of all these exercises: resistance exercise, aerobic, balance. I have a video, a simple video to tell you about the resistance exercise, which a patient can do in the home settings. It's just lifting whatever weights available at home. For example, 1 kg rice packet or sugar packet, whatever is available, or water bottle, 1 liter water bottle. They can just lift it. We have particular counts for it. We have particular measurement of what they do and how many counts and how many sets they have to do. I will talk about it later. So this is an example for upper limb strengthening exercises. So we need to target major muscle groups like deltoid, biceps, triceps. So this is how we do triceps exercise. So these are the major muscle groups of the upper limb. So 2 or 3 exercises we can do. We can select out of it and do it on day 1. Next, coming to lower extremity exercise. So again, we have larger muscle groups in the lower limbs. We have quadriceps, hamstring, and calf muscles. These are simple exercises or simple strengthening exercise which can help build muscle or maintain the muscle mass. This is for quadriceps. So just lying down, tying a weight cuff around the ankle, just lift the leg up, down. We can do it 10 times. Squats. Squats is a good exercise which will actually strengthen all the lower extreme muscles together. Squatting. Next, we have the calf raise exercise. This is to strengthen the calf muscles. Next, moving on to aerobic exercises. Just simple walking, 3 to 5 days, almost all the days of the week, 5 days, approximately 30 minutes if we walk or do a little bit of jogging. That will be of great help in this group of people. Next is the balance exercise. 20 to 30 minutes of balance exercise twice or thrice per week will help preventing falls in the elderly people. So we call something called circuit exercise. Circuit exercise program will combine both resistance and aerobic exercises, which are proved to be the most beneficial. Nice.
Why always they insist that, especially when you're above 50s and you're reaching 50s, it should be done under guidance. We always seek a master, whether you're going to a gym or go to a physiotherapy unit. We are a little scared to start on our own. And why is that is insisted that we should be guided exercises?
I'll just talk about only 2 points which tells us guided exercise is important because of the diversity of physical abilities. So we can't see 2 people having the same problems. As we see patients, we'll see one will have balance issues, one will have flexibility issues. In such cases, unless we assess individually, we'll not be able to tell them, just like giving a 4 or 5 exercises, do whatever you want. It's not like that, because the physical abilities and the physical problems patients present to us is different from one another. So we definitely need individualized intervention strategies. And then the balance, especially when we give the exercise prescription, the dosage of the exercise cannot be the same for a patient who has little younger group or a patient who's really elderly. We will not be able to follow all the instructions which we give. So we need to give the correct quantity of exercise, the volume, the progression, how a patient should progress to the next phase. If an exercise is done continuously for 2-3 weeks, and if the patient is again continuing the same exercise, there will be a stage of plateau in the muscle strength. There will not be improvement. We need to constantly alter their speed, alter their volume, alter the sets and counts. So definitely to avoid complications. Sometimes patients fall. If the exercise is not suitable for them, they may end up in breaking their bones. If at all they have a fall, so to avoid complications, it is better to have a guided, structured exercise.
So, what are the components of the structured exercises for sarcopenia?
Yes. Okay. This is an article published very recently in March 2025. This talks about the entire exercise or structured exercise session for sarcopenic people. So we usually start with warm-up exercise. See, without warm-up and cool down, we can't just get into the exercises and end up in uh, problems with the muscles like a problem with the muscle, like when they'll have cramps in the muscle, they'll not be able to do exercises in the correct pattern. So we need to give warm-up exercise. Either the patient can go for assisted exercise or aerobic exercise. So this needs to be altered every day. One day they go for assisted exercise, the next day they can go for aerobic exercise. Then we should put the patient on balance training. Then again finish with flexibility and cool down. So a structured exercise program starts with warm up. Then they have to go for assisted, then balance exercise. Ending up will be flexibility or cooling down. This is how a structured exercise will look like. Just like that, starting one exercise and then haphazardly stopping it will end up in problems and complications.
So, why should we exercise at all? Even though today's webinar is on bone and muscle health, is it the only way to improve muscle and bone health? Can we have proteins and improve the muscle health?
Okay, I talk about that. Women in midline who constantly exercise had better quality of life in their older age group. These are results of some latest studies. And being active for as many as years as possible, even if they start late, even if they start above 40 or 50s, definitely had improvements in their physical functioning and physical health, because as a patient moves from early life to adult, then to older life. See, when we see this graph, slowly the muscle power and the muscle strength gradually increases during their early life. Then after they enter into their adult life, maybe in the 30s and their 40s, it actually doesn't maintain. It actually starts dropping down. And further it stops, I mean it gradually again it goes down only in the older age. So when a person maximally works out in the early life, the strength can be maintained throughout the adult life, and as they enter into the older life, the loss can be minimized. So to prevent or delay sarcopenia development, maximize muscle in the young adulthood stage, and then maintain it in the middle age and minimize the loss in the older age.
It's a nice slogan. Maximize peak at early life, maintain peak at adult life, and minimize loss at older life is a mantra for today's program, I would say. It holds good both for bone health and muscle health.
Yes.
Uh, thank you so much, Kusalite. And we have a question talking about lipoatrophy, how to prevent it. And when I came to the department the
Actually,
other day, you had a machine which talks about the measuring the
fat
muscle,
Because,
content,
muscle and the
muscle.
fat content.
yes, ma'am.
Can we have a little more information about that?
Yes, ma'am. There is a machine called body composition analyzer using bioelectrical impedance. When a patient stands on the machine, within few seconds, it can give a report in which the patient's muscle mass, fat mass can be actually given as a report. So once we look at the report, we can work out on that patient. In certain areas, if at all, in their thighs and in their gluteal area, if at all the fat infiltration is more, we can work on them. In particular, by working on them, we can plan our exercises according to the reports. So it's just 5 or 6 seconds. It will produce a good report in which all the details of the patients, the height, the age appropriate weight or whatever is abnormal will be printed in the report. So that is a new one here. When we know what is the need of the patient, we can prescribe exercises accordingly.
And Dr. Mohan Kumar, do you have any suggestions to offer at this thing? Because you are the people who keep sending the patients to this department for keeping up the muscle strength while they're recovering from bone fractures.
No, after listening to Miss Chrysolite, I think I should start improving my muscle mass actually, because it looks because it's very important for us actually first, because first we have to be healthy, then only we can train
Yes, sir.
the patients. Because I think I should start balancing exercises and definitely strengthening exercises, because we
Yeah.
rarely do anything
So
actually.
exercises are very important to improve the bone density also. I didn't, as you said, I didn't go much on it too because it was being covered here. Regarding frailty, basically women are frail because they have lost the muscle, sarcopenia. So somewhere we have to build up the muscle, ask them to do the exercises, maybe to, I mean, give enough of diet also, unless it is cachexia. But then we will have to look at the diet also and whether it is any cancer that is responsible for it and accordingly treat it, malignancy. Otherwise, yes, we have to make them do exercises. Maybe we can cut down on the aerobic and do on the strengthening exercises so that you improve the muscle strength, and that is going to correct the frailty. So that is what I would like to say in answering the question that is put on the chat box.
So thanks for, collating all your thoughts into a beautiful presentation, Dr. Rajshri and Dr. Salite. And nicely interpreting them was Dr. Mohan Kumar sir, who gave us practical tips. He didn't mince any words when it came to MHT for osteoporosis here last time and this time. Since he's not comfortable, unless there is an indication from our side to start an MHT, that wouldn't be the first line of management for any osteoporosis. That was a good take-home point. And the second take-home point from Chrysolite is maximize peak for both
Attain
muscle,
peak bone mass.
peak
Yes,
bone mass and
maintain.
muscle mass at early life, maintain the peak in the adult life, and minimize loss in the older life should be the take-home message, I would say, for this session. And we were able to finish on time. If there are
Thank
any questions from the delegates who have joined in, thanks to the delegates who have joined in anyway. And you can put in your questions in the chat box. We will be happy to answer.
Thank
And
you,
thanks,
ma'am.
Shanti Madam, for
Thank you,
joining us,
Savitri.
ma'am.
Thank you. Savitri Madam has also joined. Thank you, ma'am.
Savitri Madam has joined. Thank you so much, ma'am.
Thank you. Really very good session, ma'am. The exercises and the sarcopenia part of it was good.
And
Sir also,
I gave them.
Mohan Kumar sir also, I mean, very clear cut take homes has been given. Very happy.
Yeah, I was very happy that in a very short notice she was able to make quick, very relevant exercises. So how much of you talk? No, this exercise, unless you see on as a video, it will not impress you. So you can now measure your own calf muscle and see if it is less than the required centimeter, and then you can come to a conclusion before, as Mohan Kumar sir said, we have to keep ourselves fit before offering any advices to our patients. That's what all of us should do as doctors. We should be healthy, and we should not be hearing all sudden sad messages in the thing, because that's what we are hearing. That's mainly because of stress, and these exercises would be a nice stress busters, I would say. These exercises, it not only happy makes your bones and muscles
Mood.
happy, it also makes elevates your mood, because of your happy hormones get liberated in large quantities during these exercises. And once again, thank
There is
Madam
one question, ma'am.
please.
Regarding the calf circumference in obese women, how are you going to monitor? What will be the change and how will you monitor if you're taking calf circumference?
Calf circumference is not always the best method, because in patients with edema, patients with other systemic disorders like thyroid and obesity, calf may not be the best one. So that is why we have other muscle mass measurements like DCA, which ma'am was asking. The machine which we were talking
Yeah.
just before, it will tell us how much fat is accumulated, how much muscle mass is there. In such cases, when a patient presents to us with obesity, it's better to take the patient to the next level of assessment.
Thank you. Yes. Thank you.
Thank you. Thank you so much. I once again thank our president, Dr. Sabat Kumari, and my classmates who have joined here. After I gave them that it's going to be a real good session for them to join in. And thanks Vijay and Rama. And thanks Mohan Kumar sir once again. And I'll be troubling you again on October 18th on a World Osteoporosis Day to have a very short session again on online. And thanks Priscilla for those lovely videos. I
Yeah,
would say
very good.
very good videos. Like it was conveying. And so we'll have more sessions with you in future as well. And thanks once again. And thanks to Chitrakala for giving
Chitrakala.
maintaining this platform, flawless platform. No hits anyway. Just
Thank you,
starting and
thank you,
ending.
Thank you. Thank you very much,
Thank you,
madam.
ma'am.
Thank you.
Thank you.
Can we
Thank
have
you
a
for the
photo?
opportunity.
Mohan Kumar, can we have your full, we are only seeing upper half of your face. Yes.
Ah,
Thank you.
yes.
Thank you,
Madam,
madam.
Shanti
Thank you very
madam.
much. It was a very nice session, very good learning experience for me.
Yes.
Thank you, sir. Thank you.
Thank you.
Singing experience that we are not doing it ourselves. Done, Napa, Chitrakala?
Yes, ma'am. Yes, ma'am.